Hi, my name is Wallaby Cabo, and I'm going to be sharing with you on the topic geriatric, violent geriatric patients. We have our objective. We have several objectives here for this topic. We're going to begin by stating them. The first objective is to be able to define what is meant by violent behavior. The next one, we want to identify the causative factor of violent behavior in geriatric patients. And we'll also be able to demonstrate the types of caring behavior and to also be able to manage behavior in geriatric patients. And we will discuss a recent nursing research contribution to this topic. By definition, according to the Mosby Dictionary, violence is defined as behavior in which an individual demonstrates that he or she can be physically, emotionally, and/or sexually harmful to others. Looking at some statistical review, we see here that violent behavior is not unique to the geriatric patient with dementia or dementia. Of this group, we know that 1/3 of geriatric patients living with dementia have one time behaved violently in their life, especially those those with moderate to severe dementia. We're going to look now at the cause or the causative factors. We have neuropsychiatric problems, and that would cause reduced judgment and increased impulsivity. Another causative factor we will look at here is multiple personal loss. That would be a loss of a spouse, a pet, or any object that they're so dear to or have been having that attachment to. We also look at as a factor for violent financial problems. Limited social support, limited mobility, negative meal experiences, difficult communicating needs to others, overstimulation of environment, depression, frequent caregiver changes, perception of rights being infringed or ignored, poor eyesight or hearing, and that will contribute to misunderstanding and misperception. We now look at some caring behavior. Within the geriatric patient population, in order to affect the violent outburst or to be able to control, if not to maintain a violent outburst, one will have to do several of these caring behavior. The first one is you have to assess the patient needs. You have to understand what the patient needs. Next to that is eliciting the patient trust. If they don't trust you, you will always appear to them as somebody strange or strangers in their face. So you want to make sure that you are trusted. And one way to do that is to make sure that you can get them to know you better, offer them stuff, like food, their favorite food, etc. Reality orientation. One good way to do that instead of letting them be all confused, which may lead to violence, is to make sure to orientate them to the reality. And you can do that by many ways using your skills as a social worker, as a nurse, as a caregiver. You may want to have the person know that they are talking to you, and by so doing, they will know where they are. You can use the power of touch after telling them that they are in there, they are at home. What we will be terming as home will be their nursing home, and most of them will be talking about I want to go home with no special plan because they're confused. So you want to make sure that you can have them remember where they are, who they're talking to, and that would be you. Reminiscent therapy. This is by making sure that they can go back in history in terms of letting them go through their photo albums, just telling you about some of their life experiences in terms of, especially those of our GRA patients that fought wars, World War One, World War Two. Those storytelling kind of really bring back some memory that can make them to really be distracted from violent behavior. Anchoring. After doing all of this, to make sure that the person stays in what you have just uh, taught them in terms of making sure that you bring them to reality, reminiscing that is, and making sure that they can keep that memory uh, just for the period of time. It may dissipate, but for that particular period of time, you care for them to be alert to themselves and the surroundings. Validating their feelings is another caring behavior. This one is huge because if you don't validate their feelings, as we see when we talk about other factors there infringing on their rights, they may think that you are infringing on their rights. So you have to validate their feelings, whatever feeling that they have or that they are expressing. Aromatherapy that can also be in line with what we just talked about touch. You can give a back rub, and that alone can bring them to some sense of reasoning in terms of reality check. We'll now look at age and gender variables, and for for age, we know that research has shown us that between ages 15 to 30 are the most violent subgroup. And next to that group comes the elderly patients who make up the next violent subgroup. And elderly male patient would tend to be more physical than their female counterpart. We all because of some predisposing factors, like example twins in the male, and the female GRA patient will uh, do more in terms of violence, verbal violence, than physical violence. Cultural consideration. Violent behavior is actually a function of the individual underlying culture, and it's actually reflected uh, in how the caregiver interpret and report violent behavior. And here, what we make it mention of is culture actually play a role in terms of uh, how far violence goes. That does not excuse an individual who may have had a violent behavior in their life or in their early uh, age. But here again, we talk about interpretation of reports, how one reports. We say culture play a role in that. We know for a fact that, for example, from where I'm from, most of our older folks stay within in the comfort of our home. So we have a very close tie with them. So in terms of reminiscing and reality or rotation, some of those can be taken care of very quickly. But here again, because of the modernization and generation shift, culture seems not to play a significant role as it did before. We can see in this uh, DNA age where generation shift has taken over with a lot of modernization in terms of the electronic world. We know that most generation of today will rather their parents be in a nursing home or somewhere where they can just come and visit. So social norms actually play a role, uh, but like I said, modernization and generation shift has kind of changed a lot around. For legal or political input, here one thing I can think about is uh, communication between healthcare teams. One is here liable, legally liable, if you don't report or give a patient report to another clinician that this patient is violent and has the potency to be danger to other clinicians. So even themselves, you have that right to let other clinicians know that this person is violent, and that's a legal liability on your part to make sure that that is done. For ethical, for ethics, we can look at beneficence, which in that case compassion, speak of compassion, and perhaps taking positive action to help others, or the desire to do good, which is the core principle of patient advocacy. So here again, we will be trying to show every compassion as we've seen in the caring behavior we discussed. Fidelity, the attitude of or which involves, say, an agreement or to keep a promise. Again, this concept of keeping a commitment is based upon the virtue of caring. You commit to caring for this person, and that goes to say that even if upon discharge or if the patient is even going to a doctor visit, you want to communicate this behavior to them so that they can be aware. We're trying to the essence is to keep the patient safe. Honest model application. We see a lot of contribution for Puna's model, but we talk about a couple of them. The first one we want to talk about is communication. And communication here, we talk about the power language, how the volume of our voice, the tone, the intonation are all important when we're communicating to our GI patients. The way we talk, at what level are we to communicate to them verbally? You want to make sure you are at a person level when you're speaking to them. So again, it can be termed as something that you are infringing on their right or maybe belittling them. Let's all remember that these individual we're speaking about were all fathers. They were fathers, they were mothers, they were auntie, they was uncle, they were brother, they were sisters. They served the army, they were pilots, they were nurses. Every walks of life you can think about. So they will be counting on you to give them that respect. So we want to make sure that when we're sharing our thoughts and feelings uh, or to them, we make sure that we're using our proper cue very well. Another one we'll be talking about will be the family role, the role of the family. Here we see the essential support system at work. We want to make sure we encourage family to visit, to meet, to be able to get whatever the client needs in terms of their request. We should be in the line of advocating for them. That can help decrease violence. High risk behavior. We are aware now that the violence should be considered a high risk behavior. But once engaged in that, it has the potency of harming others or even yourself. And again, here we're talking about uh, maladaptation to coping. And that way we would be talking about one of the theory that we selected to support this topic. Uh, we know that coping, if one is not coping adequately, it's a problem. Again, we want to also talk about the healthcare package, in which you can find all. I mean, culture is play a hero here too. But what we talking about here, we're talking about the responsibility, the individual responsibility for their health, and we're going to guide the person through our caring behavior to meet this goal. Nursing implication. We just spoke about the caring behavior, which are things that we as nurses need to care about. In addition to that, there's an acronym here. I will read. Stand for STAMPER, STAMPEDAR, and in there we see that the S is the actual thing for the use of this acronym is to be able as healthcare on a healthcare team to be able to survey your environment for warning signs in advance of a violent outburst. So by staring, looking at an individual who staring so hard, you'll be able to tell whether that person is uh, getting at a point of being violent. Their tone, you watch their anxiety level. Are they increasing? Mumbling, that may signal anger. Pacing, that may also signal anger. Their emotion, are they crying? Which may also signal depression. And we talk about assertive and our resources. Those things that we need to make sure that we can be able to carry through. Nursing article contribution or for this topic. Our current nursing research will be physically violent behavior in dementia care, characteristics of resident and management of violent situations. We have four authors of this article, and they are Alpha Atkinson, Eula H. Birmingham, Stuart A. Strom, and Steve Carson, all of whom are from the Department of Nursing, Umeå University in Sweden, the Caring Science Building. The objective of this research was aimed at to explore types of caring situations, resident characteristics related to physical violent behavior, or what we may term PVB, and professional caregiver management of PVB. The method used, the study included 40 group homes for 309 residents with dementia. The data were gathered by means of structured interview, dimensional dementia assessment scale, and GRA rating scale. The result, 98 of the residents, which make up 31.7%, were assessed as showing physical violent behavior during preceding week. Three factors were responsible for this behavior. One was independently associated with male gender. Another one was the use of antipsychotic medication or treatment, and last, the decline in orientation. That could also be mean decreased judgment also. Violent residents were more likely to have impaired speech, difficulty understanding verbal communication, and prescribed analgesic and antipsychotic than were non-violent residents. So those that actually did all of that were more likely to create violence than the non-violent person. If there was a male gender, that would be a key factor for a violent behavior. And we know that they also said that this behavior occurs mainly in intimate helping relation or situation, and they use the symptom-oriented approach to manage such behavior, such as distraction, medication, and isolation. The working team they concluded by saying that physical violent behavior is frequently displayed among residents in group homes for a person with dementia, and the caregiver mainly manage PVV using symptom-oriented way. To enhance the quality of care, the research at patients with dementia, there is a need for intervention that aim to understand and manage the resident physical violent behavior. And that's the key. That's what they brought us back to. The whole thing is to be able to manage and to be able to control the physical behavior. And we talk about that on the caring behavior, using the caring behavior, and then using the STEMPADI, the STAMPEDAR, where you be able to watch for those warning signs to be able to inform you earlier before a violent outburst. And that ends this topic. And thank you for actually tuning in and listening to me. Thank you very much.